part of all that money we spend on healthcare goes to making sure that we're instituting good health policies, right? Wrong. That's the topic of this week's Healthcare Triage. Special thanks to Austin Frack, from whose Upshot column this episode was adapted. A few years ago, Oregon found itself in a position that you'd think would be more commonplace. It was able to evaluate the impact of a substantial, expensive health policy change. In a collaboration by the state and researchers, Medicaid coverage was randomly extended to some low-income adults and not to others, and researchers have been tracking the consequences ever since. Rigorous evaluations of health policy are exceedingly rare. The United States spends a tremendous amount on healthcare, but very little of it learning which health policies work and which don't. In fact, less than 0.1% of total spending on American healthcare is devoted to evaluating them. As a result, there's a lot less solid evidence to inform decision-making on programs like Medicaid or Medicare than you might think. There's a similar uncertainty over common medical treatments. Hundreds of thousands of clinical trials are conducted each year, yet half of treatments used in clinical practice lack sound evidence. As bad as this sounds, the evidence for health policy is even thinner. A law signed this year, the Foundations for Evidence-Based Policymaking Act, could help. Intended to improve the collection of data about government programs and the ability to access it, the law also requires agencies to develop a way to evaluate these and other programs. Evaluations of health policy have rarely been as rigorous as clinical trials. A small minority of policy evaluations have had randomized designs, which are widely regarded as the gold standard of evidence and commonplace in clinical science. Nearly 80% of studies of medical interventions are randomized trials, but only 18% of studies of U.S. healthcare policy are. Because randomized health policy studies are so rare, those that do occur are influential. The RAND health insurance experiment is the classic example. This 1970s experiment randomly assigned families to different levels of healthcare cost sharing. It found that those responsible for more of the cost of care use far less of it, and with no short-term adverse health outcomes, except of course for the poorest families with relatively sicker members. The results have influenced healthcare insurance design for decades. In large part, you can thank or curse this randomized study and its interpretation for your healthcare deductibles and copayments. More recently, the study based on random access to Oregon's Medicaid program has been influential in the debate over Medicaid expansion. A state lottery, which provided the opportunity for Medicaid coverage to low-income adults, offered rich material for researchers. The findings that Medicaid increases access to care, diminishes financial hardship, and reduces rates of depression have provided justification for program expansion. But its lack of statistically significant findings of improvements in other health outcomes has been pointed to by some as evidence that Medicaid is ineffective. Although there are other examples of randomized studies in health policy, the vast majority have far less rigorous designs. Some of them are sponsored by the Center for Medicare and Medicaid Innovation, created by the Affordable Care Act. It has spent about $1 billion a year on dozens of programs that pay for Medicare and Medicaid services in new ways intended to enhance quality and reduce spending. Most of the Innovation Center's pilots lack randomized designs, for which it has been criticized. Also potentially problematic, most of its programs rely on voluntary participation by healthcare organizations. There might be crucial differences between those that opt in and those that don't. Mandatory participation poses its own set of financial and political challenges. Randomization can also be challenging. It can be complex and hard to maintain. Problems can also plague rollouts that are voluntary and not randomized. Programs showing promise suffer from diminishing participation as healthcare organizations drop out. The Innovation Center's Pioneer Accountable Care Organization program offered healthcare organizations the opportunity to earn bonuses in exchange for accepting some financial risk, provided they meet a set of quality targets. It started with 32 participants in 2012. Although studies showed it reduced spending and at least maintained, if not improved, quality, only 9 remained by 2016 when the program ended. Some of the largest Innovation Center programs, involving thousands of providers, bundle payments across services for some common treatments, like knee and hip replacements, instead of paying separately for each one. More efficient providers that can deliver the care for less than that price can keep some of the difference as profit. Those that can't lose money. Of 6 bundled payment programs, only 1 included random assignment. Beginning in April 2016, Medicare randomly assigned 75 markets to be subject to bundle payments for knee and hip replacements and 121 markets to business as usual. But the Innovation Center didn't maintain the design, announcing in November 2017 that hospitals could leave it. This will greatly limit what can be learned from the program. Just as in clinical care, there are examples of incorrect thinking based on low-rigor studies that more rigorous ones later overturn. For example, many low-quality studies suggest that wellness programs reduce employers' healthcare costs as they improve health outcomes, but when the programs have been subject to randomized controlled trials, none of these findings hold up. Hospital cost shifting. The idea that shortfalls from Medicare or Medicaid cause hospitals to charge higher prices to private insurers can also seem commonplace from studies without rigorous designs. But when subject to more careful evaluation, the phenomenon is almost never observed. An apparent preference for ignorance is not unique to healthcare. Policies across governments at all levels are routinely put in place without plans to find out if they work, or how to unwind them if they don't, or how to build on them if they do. A 2017 Government Accountability Office report found that the vast majority of managers of federal programs were not aware of any recent evaluation of the programs they oversaw. In most cases, none had been done. In others, none had been done in the past 5 years. It's hard to rid ourselves of ideas that are little more than wishful thinking or to end policies that don't work. The first step would be to do more rigorous policy evaluations. The next would be to heed them. Hey, did you enjoy this episode? You might enjoy this other episode on the randomized controlled trial and how wellness programs were busted by them. It's a really good episode. You can also support the show at patreon.com/healthcaretriage, where, like our research associate Joe Sevitz or our Surgeon Admiral Sam, you can support the show as much as you like. Help us make it bigger and better.